in terms of another pharmacokinetic study, which we hope will lead to some important clinical trials, I'd like to invite Patty Mitre to come and speak with us here. Patty is a pharmaceutical scientist from Mexico, chemist, different definitions in different countries, who came to visit us a number of years ago, just on a very short placement. And within a couple of days, I knew that she was so amazing that we had to get her back. And so I was absolutely delighted when she enjoyed her time in Australia enough to decide that she wanted to come back to Australia and make it her home. And so she is an Australian resident, and she is an amazing pharmacometrician. And she's going to tell you a little bit about what that is in the context of antifungal drugs, which of course are used to treat very tricky infections, which have a terrible outcome possibility for patients. And so without taking any more of a thunder, Patty, please.
That was very nice. Thank you. Today I will talk about the SAFE-ICU study. I'm very limited on time, so I'll try to go through very fast. All right, I'll start talking about fungal infections. These infections are becoming more common in hospitals, and they can spread in different ways, including through healthcare workers, medical equipment, and hospital environments. These infections can be very serious, especially in critically ill patients. Now, in critically ill patients, these infections are associated with substantial morbidity and mortality. And this population, critically ill patients, often have major changes in how drugs are moved through and are processed by the body. Organ dysfunction, fluid shifts, and other medications can make drug exposure difficult to predict. And as a result, a standard one-size-fits-all dose may not provide enough exposure, and the treatment may not work as well as we expect. It is also difficult to assess the patient's response quickly because the signs of infection are often nonspecific and they take time to change. And because drug exposure can be unpredictable, dosing quality is not simply about giving a standard dose. What matters is whether the dose achieves the target exposure, and this is associated with better patient outcomes. Most of the existing PK data are coming from small single-center studies, and while these are very useful, they are not always generalizable and may not provide strong evidence to guide dosing in critically ill patients. One example is the DALI study, which was a very important multi-center study that helped define antibiotic exposures in intensive care unit patients. However, antifungal data was very limited, leaving an important gap in our understanding of antifungal exposure in this population. And to address this gap, the SAFE-ICU, which stands for Screening Antifungal Exposure in Intensive Care Units, was established to generate this comprehensive data on antifungal pharmacokinetics in ICU patients. Its objective was to determine whether contemporary antifungal dosing achieves therapeutic exposures that are associated with optimal outcomes in critically ill patients. This was a prospective, open-label, multi-center PK study conducted in adult intensive care units. Critically ill adults aged 18 years or older were enrolled according to the predefined inclusion and exclusion criteria. And the study included 3 major classes of antifungal agents: azoles, echinocandins, and polyens. And of course, the choice of antifungal agent and dosing regimen was determined by the treating clinician. I'll now explain where the PK samples were collected. So PK sampling occurred on 2 different occasions. The first one was during a dosing interval between days 1 and 3 of antifungal course in the ICU. And the second occasion was during a dosing interval between days 4 and 7, where hopefully steady state was achieved. And then on each sampling occasion, 3 blood samples were collected across the dosing interval via an established intravenous catheter. Sample A was collected 30 minutes after completion of the IV infusion, and for enteral dose, it was collected 30 minutes after the dose was administered. Sample B was collected between 3 and 6 hours after the start of the infusion, And sample C was collected within 30 minutes before the next scheduled dose. Then all the samples collected at all the participating sites were transported to Brisbane for analysis, and total plasma concentrations of the study antifungals were measured using validated chromatographic methods at the UQCCR by the amazing lab team in level 7. Where's Dushan? You're on TV. And then these concentration measurements were then used to estimate drug exposure and assess the PK/PD target attainment. The area under the concentration time curve from 0 to 24 hours was estimated using non-compartmental analysis in Phoenix Windalin, and the concentrations measured in samples A and C were considered the observed maximum and minimum concentrations, respectively. Then, to assess target attainment, we used the measured minimum inhibitory concentration when it was available. But when an MIC was not available, we used the relevant UCAS epidemiological cutoff value. And where no fungal species were identified, we just assumed the highest MIC among susceptible species, providing a conservative worst-case scenario. With the exposure measures and the MIC assumptions defined, we then assessed the PK/PD target attainment across the study population. So let's have a look at the results. In total, 339 patients were included from 30 ICUs across 12 countries, including Australia, Belgium, Canada, USA, Finland, Greece, Portugal, Hong Kong, Italy, Malaysia, and Spain, highlighting the international scale of this study. Most antifungal therapy was prescribed for treatment rather than prophylaxis. Fluconazole was the most frequently prescribed antifungal, and fungi were identified in 54% of patients prescribed treatment, but in only 7.7% of those receiving prophylaxis. The most frequently identified species were Candida albicans, Candida glabrata, and Candida parapsilosis. And importantly, MIC data were available for only about 1/4 of the identified species, of the identified isolates. And by day 30, nearly 40% of patients had died. And of those, 88% were receiving antifungal therapy for treatment. Now, 9 patients received a second antifungal, and 1 patient received a third antifungal, giving a total of 349 antifungal courses. Almost all courses were sampled on occasion 1. For about 1/3 of these courses, antifungal therapy was commenced within the previous 24 hours. And around 2/3 of this population were sampled again on occasion 2. And you may be asking, why only 2/3? Well, because most of them had died by then. So across both occasions, 579 courses were sampled. Target attainment could not be determined for 46 courses because there were fewer than 3 samples, or the sample timing was not suitable for estimating the area under the curve. Now, I will very briefly present the PK/PD target attainment results for each antifungal. So this table shows the target used, the number of courses evaluated, the mean daily dose, and target attainment on each sampling occasion. The colors are just simply a visual guide, and they are not based on statistical analysis. So for fluconazole, target attainment was high. More than 80% of treatment courses and more than 90% of prophylaxis courses achieved the target on both sampling occasions. The weight-based daily dose was significantly lower for prophylaxis than for treatment. As with fluconazole, the weight-based daily dose was significantly lower for prophylaxis than for treatment for voriconazole. The target attainment was lower for treatment, reaching 53% on occasion 1 and 38% on occasion 2. Target attainment was also higher for prophylaxis, although only 7 prophylaxis courses were included. Posaconazole showed higher target attainment for prophylaxis and very low for treatment, although the number of courses was small. And isavuconazole showed mixed target attainment with generally higher attainment on occasion 2. However, these results should be interpreted cautiously because only 10 courses were included. Anidalafungin showed relatively high and consistent target attainment at around 75% or greater on both treatment and prophylaxis across both sampling occasions. And caspofungin showed high target attainment exceeding 80% for both treatment and prophylaxis at both sampling occasions. As with fluconazole and voriconazole, the weight-based daily dose of micafungin was significantly lower for prophylaxis than for treatment. This agent showed moderate target attainment for treatment, but lower for prophylaxis, where only around half of the courses reached the target. This was the first large-scale international prospective study to examine PK/PD target for antifungal agents in critically ill patients. And lastly, deoxycholate amphotericin B was still being used at some sites, although the liposomal formulation was more common. Both formulations showed low target attainment. For the liposomal formulation, attainment remained below 60% in both sampling locations, and no deoxycholate courses achieved the target, although only 2 courses were included. So this was the first large-scale international prospective study to examine PK/PD target attainment and dosing adequacy for antifungal agents in critically ill patients. By including 30 ICUs in 12 countries, the study provides a much broader picture than the smaller single-center studies available. So the findings reveal that overall prophylaxis performed better than treatment for most antifungals. At first sampling occasion, more than 25% of patients did not meet the predefined target exposures. In particular, voriconazole, posaconazole, micafungin, and amphotericin B were among the antifungals with the lowest target attainment. And together, these findings suggest that contemporary dosing may not reliably achieve target exposure for these antifungals in critically ill patients. And they highlight the need for improved dosing strategies that account for substantial PK variability seen in critically ill patients, rather than relying on standard dosing alone. We should also keep in mind that for antimicrobials, the adequacy of a dose also depends on the susceptibility of the infecting organism. Contemporary dose may be sufficient for species with lower MICs, but insufficient when the MIC is higher, even if the isolate is still classified as susceptible. So this highlights the importance of identifying the causative organism and obtaining an MIC where possible to support dosing decisions. And that appropriate loading doses may be important for achieving adequate exposure early in therapy. Target attainment was often higher at the second sampling occasion, and this might partly reflect drug accumulation towards a steady state, particularly because nearly 30% of courses sampled on occasion 1 had only commenced in the previous 24 hours. Well, of course, it has a bit of limitations. The PK/PD targets for selecting these targets for treatment and prophylaxis can be challenging. Some targets, including those for amphotericin B and isobuconazole, have not been adequately established. And assumptions were required when MIC data was unavailable or when no fungal species were identified. And of course, these assumptions may have influenced the estimated target attainment. Also, drug exposure was estimated from only 3 samples, which may have reduced the accuracy of the estimates. However, this approach has been used in comparable multicenter studies, such as the DALI study. And finally, only total drug concentrations were measured. So this may not fully reflect active and bound drug exposure, particularly in critically ill patients with altered protein binding. But despite this limitation, this study provides important international data on antifungal exposure in critically ill patients. So in conclusion, this large study showed substantial variability in target attainment across antifungal agents in critically ill patients. And although many patients achieved the targets, subtherapeutic exposure remained common for several antifungals. So that's for me. Thank you for your attention.
Fantastic, Patty. So that's an example of a pharmacokinetic study which has defined a problem which had been hypothesized about inadequate antifungal dosing in critically ill patients and has actually led to a clinical trial called the Pragmatic trial, which is currently being run by our group across 6 hospitals across Australia and the USA.